Hello, everyone. Welcome to our virtual spine conferences today. My name is Chao. I'm currently Dr. Ali Bosch, Clinical Spine Fellows. Today will be me to give a presentation regarding the anterior versus posterior approaches for cervical spondylitic degenerative cervical myelopathies. Before I start, I want to confirm, can everybody hear me? Okay, I'm gonna share my screens. Let me know if you cannot see it, okay? All right. If in middle of this talk, so if any questions, you're welcome to have give me any questions or anything. And of course, in the end, we're gonna give a short period of time so talking for any questions or comments. All right, let's start it. Before I started, I want to tell, before I forgot, just tell you that I don't have anything to disclose. I'm currently a clinical fellow at University of Arizona Phoenix Medical School at Banner University Medical Center in Phoenix, and Dr. Alibash is my program director. And a little bit more about me is I graduated from Des Moines University, and then I'm matching to the neurosurgery residency at the Regional Medical Center in California. And after that, I came to Phoenix to continue my complex spine fellowship here in Phoenix. All right, we started a little bit about the surgical treatment for degenerative cervical myelopathy. Currently in the United States, the moderate to severe, especially symptomatic, the cervical myelopathy are commonly surgically treated, especially in the United States. And they're, of course, including the anterior versus posterior approaches. Which one is superior remains very debatable. There are being many studies for comparison these two approaches. And today's talk, I've tried to bring the most updated one, which I found it online, to introduce a little bit history and also the major researchers concerned for this topics. And the first prospective random controlled trials study was published in 2020 by Egypt, the groups. It's actually showing that it was anterior approaches that significantly improved the postoperative function outcomes. And about 1 year later, and there's another study was published in the United States, researchers, which I'm going to introduce this study to, is published in the JAMA, which is called Cervical Spondylitic Myelopathy Surgical Trials, indicating these two approaches are similar in terms of the postoperative function outcomes. So this is the first 2020 studies, which is published in the JNS, talking about the safety efficacy of anterior versus posterior decompressive surgery in degenerative cervical myelopathy in the prospective random trials. And throughout this talks, I'm actually will highlighting several of the important, interesting things which I found it out. And also I will do some basic concepts introduction for somebody who is not familiar with some of the key parameter there for the measurement of the outcomes. So this is the first time ever the prospective randomized trials, the patient has a symptom or signs of the degenerative cervical myelopathy, was randomized assigned to the groups either anterior ACDF fusion or posterior laminectomy with or without fusions. So that means that for the anterior approach group, there are always fused, but the posterior approaches, there may or may not be fused. The primary outcome measurement including visual analog scales for pains, neck disability index, neurorectal myelopathy grade for 1 year after the surgery. Secondary outcome including the intraoperative, postoperative complication, hospital stay, all those criteria, etc. The follow-up period time is up to 1 year. Interestingly, I'm going to show for every study, if I have the data, I'll tell you that how many levels their study included. For this studies, the anterior and the posterior approaches are involved in the maximum level of the same, from 1 to 5. And interestingly, which is, I'm going to tell you that it's for this study is that the 5-level ACDF only have 1 operations. So a little bit introduction for in cases somebody we're not familiar with neck disability index, NDI is a questionnaire assessing your neck pains. The scoring ranges from 10 to 72% for the classification, from the mild disability for severe to complete disabilities. Neuric classification myopathy is actually 6 grade scale. Scales is from 0 to 5. 0 is the sign symptoms of only root involvement. 5 is literally this patient with a chair bonded or bad regions. Oldham criteria is actually 4 points of the rating score from poor to excellent to actually assess the clinical outcome for spine surgeries. Interestingly, it was actually usually was assessed by the treating surgeon instead of the patient him or herself. So for this studies, there's a total only 68 patients. And you notice that there's I highlight over here in this slide, this is 72.3% are the males. So the majority of the patients are males. So there are showing there's a significant NDI and VS scores in the anterior groups, which is also the statistically significant. And but for neuritic myelopathy grade showing no differences, we're using posterior approaches. And of course, you can see that the mean operating duration is significantly longer in the anterior approaches, but there's no significant difference between posterior complication except the dysphagia, which is, as we all know, that's one of the very common complications involved with anterior approaches. But there's, other than that, there's for posterior operative patient satisfactory or hospital, there will be no difference, but hospital stays longer in the posterior groups. So their conclusion for this study showing that is in the multi-level degenerative cervical myelopathy, anterior approaches is significantly better regarding the pain, NDI, and a hospital stay. However, the posterior approaches is better in terms of postoperative dysphagia and the durations. All right, this is the first, the random prospective random trials, and then I'm going to talk about the year later, the United States group published one, which is also random clinical trials, so it's positive JAMAs, which is give a different conclusions. So this is the study is clinical trial for age of 45 to 80 patients in North America from 2014 to 2018. And there are follow-up periods, at least 1 year too. There are 63 are from anteriorly and hundreds are posteriorly. The ventral surgery, including ACDF, is interesting. They don't have a 1 level. They started with 2 levels to 4 levels. Posterior approaches is laminectomy and also laminoplasty. So here they include laminoplasty, which is the differences compared to the first studies. And the type of the posterior surgeries, whether it's fusion or laminoplasty, is up to the surgeon's discretions, but they treat it as similarly. And here is the several concepts which they use for their studies, which is a little bit different from the first one, which is they include in the one which is SF36. It is a 36-item scale measured to 8 domains of the health status, from functionality, physical limitation, body pain, is actually to assess patients' disabilities. And also there's a very common one we're using for the spine surgery. It's called a modified Japanese Orthopedic Association scoring system. And this is a scoring system from 0 to 18, which is involving upper lower extremity motor function, upper extremity sensory, and sphincter function, determine the severeness of the myelopathies. And also, there's another concept they're using is EQ5D, which is the health-related quality of life development. There are values based on indexes and score utility to assessing patient status of the quality of life. At this result, there's 163 patients, which is the group of the study groups is relatively bigger compared to the first study. And also, their female and males are almost 1-to-1 ratios. They follow up completed trial at a year, and 80% of them at 2 years. And there are some due to their crossover because they didn't receive the surgery allocated. So they're showing that SF36, quality of life, there's no significant difference between the anterior to the posterior approaches. And the rate of complications and the anterior and posterior groups are the 48 to 24%, which is significant, including dysphagia. And you notice that in the posterior approaches, there's no dysphagia. The anterior is 41%. New deficit, 2% in the anteriorly, 9% in posterior approaches. Reoperations, similar, 6% anteriorly and 4% posteriorly. And of course, the readmission rate within 30 days, 0% anteriorly and 7% posteriorly. All right, here is the of most recent systematic review with a meta-analysis was published in 2023. The WNS joined section the disease, joined the section in disorder in spinal peripheral nerves. It was published in GNS Spine in 2023. This is a pretty big random, pretty big systemic review and meta-analysis studies. Apparently, including all the parameters I mentioned before, that is including NDI, physical component, modified Japanese scale, pain, EQ5D, secondary including operation duration, hospital stay, etc. And here are listed, highlighted here, that is their interventions for the anterior approaches, including corpectomy. Compared to the previously 2 studies, which is none of them including the corpectomy. Posterior approaches, they notice that it's including either LAMI with fusion, or LAMI without fusion, or with an abdominoplasty. So this is the random. This is meta-analysis studies actually including various different kind of anterior posterior surgical techniques involved, which is, I think, they may have some impact for the outcome of the recommendations. As for the results, there's over 8,000 patients was included, and anterior approaches 49.4 and posterior 50.6, almost 1-to-1 ratios. And they are the level getting involved. They're pretty similar, so 3.1 to 3.5, which is, I will tell you a little later details about the levels, because anterior approaches as well, we got involved on daily practices that, up to 3 or 4 is kind of difficult and hard. If we're going beyond that, it's actually, we're more concerning pseudoarthritis or something like that one. Multi-segments, is a consideration for surgical choices. But anyway, I will explain more details in this studies. How many assessed they during their researches are having, how many levels. It's very interesting findings. So at 1 year's follow-ups, the mean differences for NDIs at 36 VS score between these groups is they found out that the mean differences scores grade higher in the ACDF groups, and the differences were not clinical significant, to give them a minimal clinical important differences for 2 and 0.5 respectively. In the ACDF groups, the mean differences in the operation bleeding is currently smaller, which is negative 1.77 millimeters. And also they have a relatively shorter of the length of stays. And however, dysphagia is higher currently, and also the OR for the incision infection, skin incision infection, CPAP palsy for the anterior approach is also smaller. But other than that, all other outcomes are similar. So their conclusions for this meta-analysis are showing that is similar finding regarding the function outcomes. And ACDF apparently is beneficial for the terms of less bleeding, shorter length of the stay, and lower odds of the infection CPAP palsy. But apparently it does carry higher odds of the dysphagias. And so they recommend it, apparently they individualize for surgical decisions. And there is an interesting finding, which I mentioned before. There are total 16 studies they accessed. So 5 of them didn't report any levels. They're involved. There are 5 that reported there are anterior posterior approaches are involved. The maximum levels are the same, up to 5, believe up to 5 levels. Some that were 4, mostly 4 and 5 levels. 6 of the reports reported more level in the posterior approaches than the anterior approaches. And there's no studies in all of the 16 studies, none of them reported there's more anterior approaches involved levels compared to the posterior approach levels. This is also the study was published roughly 8 years ago, but there are assessed a different database called a quality outcome database. This is actually a neurosurgical spine databases, which is I believe they're related to CMS. They using that database to assess the anterior following posteriorly for the outcomes for degenerative cervical myelopathies. And so they search it. There are 3 to 5 level degen myelopathy. Anteriors, they either do ACDF or corpectomy with fusion. Posteriorly, they do with fusion only. So this is slightly different compared to the first 3 studies which I mentioned before. And they're using the similar outcomes measurement, including NDI, NRS, modified JOS, or in-assay satisfaction score, or whatever. They're similar. There are total 245 patients analyzed. There are more in the anterior approaches. 116 are ACDF, 47 are corpectomy, and 82 go into posterior surgery, including fusions. They follow up with 90 days for NDI, QD5, NIS, and the MJOA and satisfaction scores between these two. They found that there's no differences significantly between anterior and posterior approaches. But they found it out for their secondary outcome. They found out patients who doing 3 to 5 level degenerative cervical myelopathy with anterior approaches have a shorter hospital stay compared to patients doing posterior approaches. They're both showing in the similar long-term patient-reported outcome, readmission, or return to work rate. This is almost 10 years ago. It's another meta-analysis, a family review study. It was published in one of the Chinese groups. They're using slightly different database assessment. I'm just doing a brief introduction for the studies. So they just did a conclusions, very interesting conclusion. They found out the anterior approach is associated with better neural functionalities than the posterior approaches in treating multi-level cervical spondylitic myelopathy. However, there's no apparent differences in neural function recovery rate. And they also found out complications, reoperation rate is significantly higher in the anterior group compared to posterior groups. Apparently, there's a more common surgical trauma associated with corpectomy compared to posterior lamelloplasty or lamellectomies. It's very interesting finding based on this group's of studies. I'm gonna, for all the studies for the last 4 one, which is more focus on the neurofunctionalities one, which is I'm going to talking more about anterior versus posteriorly with several different topics. This one is talking about the kyphotic cervical spondylitic myelopathies for versus anterior for posterior approaches. And then later on, I'm going to talking about more about long-term follow-up and narcotic usage, even the cost. If you're interested, there's a lot of interesting findings for all the studies. So this is a retrospectively studies for 117 patients for the kyphotic cervical myelopathy, and then 58 of them doing the anterior fusion and 59 of them doing posterior fusion between 2016 to 2020. Because this is more, this study is more focused on the alignment, also the functionality, the primary outcomes. So they are using a curvature index C27 Cox angle, and they measure the pre and the post based on the lateral radiographic images. Then they calculated the recovery is based on the GOA scores, axial symptoms and severity based on the neck disability indexes. So after the analysis, they found that there are the significant differences between the cervical curvature indexes, COB C2 to C7 COB angle, and also NDI between the two groups. But however, for the GOA scores for myelopathies, there's no differences between these two groups significantly, and also recovery rate too. They found it out. There is a correlation between the curvature index, which is correction of the curvature. They both are improving the curvatures, but they found out anterior groups have a relatively higher correction rate compared to the posterior approaches. So their conclusion is they're both anterior and posterior fusion are providing satisfactory neurologic improvement. They found it out. Cervical kyphotic corrections is actually can have a significant improvement for the axial symptoms, and which is also they found out it favors the anterior approaches more favorable for the posterior approaches. Of course, as the conclusion, they're always saying that they have to be individualized for each different cases for surgeon to choose anterior and posterior approaches. And this is the one study was published in 2018. I believe this is one was Jordan Groups and published is actually talking about the long-term follow-up, because all the study which I mentioned so far are talking about up to 1 year, at least a 1 year follow-up. But this is the study actually talking about up to 5 years compared anterior to posterior approaches. Are there any differences? So this is a retrospective study involving 140 patients, and it had at least 5 years follow-up for the full clinical score and radiographic evaluations. For the posterior approaches, there are 73. They're including decompression, lateral mass screw, and fusions. There are 67 going to anterior decompression with fusions. They're using the NDI scores. They are using local score. This local score there is only individualized questionnaire for clinical outcome. They're also used actually for evaluation of patients. Their conclusion is there's no significant difference between the clinical and radiographic results compared to anterior versus posteriorly for surgical treatment for cervical myelopathies up to at least 5 years follow-up. I think that somebody have questions. All right. So, all right. So this is a very interesting topic. It was a group from the UCI. It was published, I believe, recently. I don't know which year was it. Talking about the cost analysis between the anterior versus the posterior approaches for the spine. And so there are 276 patients, and there are 1 to 3 levels between 2015 to 2019 in the single institution compared anteriorly posterior approaches for degenerative cervical diseases. they found it out that there's no significant anterior versus posterior approaches for the hospital cost or net revenue or contribution margins. But here, they did further studies. They found out there is a two factor which is was associated very significantly with a lower contribution margins. Based on my understanding for this article, it means that this two, age and length of stay, have a huge impact or confounding factor to to delineating the differences between anterior and posterior groups. So what they did in this group is take off these two confounding factors, age and length of stay, and they do the analysis. They found out the margins is actually significantly higher in the anterior versus the posterior approaches. So they said that they did a further explanation. They believe that because the posterior approach surgery are typically performed on older patients, which requires a longer hospital stay. Because currently the insurance pay as packages, if the patient requires a longer hospital stay, then their margins will be reduced. And this is another study was published in 2022. Is talking about the narcotic usage compared to anterior for the posterior approaches for multi-level cervical degenerative myelopathies. So they found it out that the posterior approaches associated with increased rate for inpatient complication, wound complication, 30 days readmission, 1 year's pseudoarthritis, 1 year's revision or extension surgery. And then also, interestingly, they demonstrate they have a higher level for narcotic usage up to 120 days after surgeries. All right, this is all today's my talks. And anybody have any questions? If you have any question, you can raise your hand or type in. I will be able to see it and I'll answer it. Okay. All righty. If nobody have a question, that's today's presentation. Thank you very much for your time. Have a good day. Thank you.